Hi guys, good evening. So, continuing our series on BLS, today we'll be talking about breast. So, we're starting breast from this week onwards. So, couple of weeks we'll run over the breast, and then as we go forward, we'll take it more. Okay? All right, so let's begin the discussion for today. So, we'll be talking about the surgical anatomy of the breast, its orientation, and then various pathologies in breast. We'll start with the benign disorders, and as we start with the benign disorders, we'll move into the malignant disorders as well. Hello, Mehak. Good evening. Okay, chalo. So we'll be starting breast. It's going to be quite interesting topic. It is one of the most frequently asked exam questions as well. A lot of cases that you see in our OPDs as well as during your postings will be a lot of breast lumps. So we'll try to analyze and get on the context that what exactly are we going to talk in the breast chapter completely. Okay. So we'll start with the breast basic discussion, and one of the basic thing that you need to know it is if somebody asks you to define breast, right? The best way to define breast, it is defined as a modified apocrine sweat gland. It is a modified apocrine sweat gland, right? So the best way to describe a breast, it is going to be a modified apocrine sweat gland. Now look at the orientation of the breast, right? So you see a breast that is going to extend all the way, craniocaudal extension like this, right? So look at the extent of the breast. So when we talk about the extent of the breast, the upper extent, that is cranial extent, it is going to be starting all the way from the second rib, and this is going to extend all the way to that of the sixth rib. So the craniocaudal extension of the breast starts from the second rib, ends at the level of the sixth rib. And if you talk about the nipple, usually the nipple will fall equidistantly from these places. So I can say on an equidistant space, this is going to be present at the level of the fourth rib. So this is your entire breast parenchyma that is there, right? Now this is going to rest upon a surface, right? So this resting surface on which it is going to be present. The resting surface which is going to be present will be called as the pectoralis fascia. So you see this is going to be running through and through, right? So this filmy layer which is going to be present, which is going to be present behind the breast, or it is basically putting the breast on top of it, it is what we call it as the pectoralis fascia. This is what we call it as the pectoralis fascia. Now behind the pectoralis fascia, you have the muscles on which the breast is going to rest upon. So what are the muscles that you have? The muscle that is going to extend in the majority of the breast, this is what we call it as, yes, you're right, this is your pectoralis major muscle. So the muscle on which it is going to rest upon, this is what we call it as the pectoralis major muscle. So muscle that you're looking across right now, this is what we call it as the pectoralis. This is your pectoralis major muscle. So when we say the breast is going to rest upon two muscles, by impulse it just comes out that you say it is going to be your pectoralis major and the pectoralis minor muscle. It is not. The lower part of the breast which you can see here, this is going to be supported by another set of muscles, and these set of muscles which are going to be present on the lower part of the breast, and this is what we call it as the serratus anterior group of muscle. So if you look very carefully, certain things are very, very clearly placed. This fascia, which is called as the pectoralis fascia, it is going to rest upon two distinctive muscles. The one is your pectoralis major. The another set of muscle is going to be your serratus anterior group of muscle. Another one is the serratus anterior group of muscle. And then you see there is another muscle which is going to be present behind the pectoralis major. And this muscle which is present behind the pectoralis major is what we call it as the pectoralis minor muscle, right? So this is your pectoralis minor muscle. This happens to be your pectoralis minor muscle, right? You see the entire component of the breast is going to rest upon this filmy layer which is called as the pectoralis fascia. Behind the pectoralis fascia, you have two muscles, the pectoralis major and the serratus anterior, which is providing the resting surface of the breast, and behind the pectoralis major you have the pectoralis minor muscle. So do not goof up when I ask you that what are the resting muscles of the breast. The breast rests upon two muscles. One is your pectoralis major, another one is your serratus anterior group of muscle. Now a very important concept before we move down, you need to understand what is chest wall. Now as we move forward, you will understand that in the entire chapter of breast, I'll be trying to tell you that how to diagnose breast cancer or how do you rule out breast cancer. So the whole focus is going to be around that area. So when you say chest wall is made up of three important components. Number one is ribs. Number two, it is the intercostal muscles. One is the ribs, another one is the intercostal muscles, and the last one is the serratus anterior group of muscle. So you have the ribs, the intercostal muscles, and the serratus anterior group is what we call it as chest wall. The carry-home message that you need to understand that when I say chest wall, you will notice that chest wall does not include the pectoralis major or the pectoralis minor muscle, right? Abu, we have completed trauma last week, as I have told. That was the last lecture on trauma. So I started breast from this week onwards. For the next couple of weeks, we will have the breast is the area of focus, right? So you have the chest wall. The chest wall is made up of three important components: the ribs, the intercostal muscles, and the serratus anterior group of muscles. The pectoralis major and the pectoralis minor do not form the component of chest wall. Now, why this is important is when we speak about breast cancer, as we go forward, I'll be talking about the breast cancer. Now, as I speak about the breast cancer, we'll be talking about the staging of the breast cancer. And there I would say that if there is involvement in breast cancer, if there is involvement of the chest wall, this will be called as a T4A disease. We'll talk about it, what is the staging and all that. For now, you have to remember, if a breast cancer is there and if it is infiltrating a chest wall, the disease stage will become T4A. But how do you know it is chest wall involved? Either it will be involving ribs or the intercostal muscles or the serratus anterior group of muscles. Involvement of pectoralis major will not make it to become stage as T4A. So involvement of pectoralis major does not alter the staging, but involvement of chest wall definitely alters the staging. Now, this is the basic orientation of the breast that you have, the craniocaudal extension you have, the resting surface is there, the membrane which is going to present on, the muscles which are going to present. This is a basic objective. But as a surgeon, this is not going to help me because I don't know the I don't know the mediolateral extension of the breast. I know the craniocaudal, that is the head to toe, but I don't know the mediolateral extensions. For that, I need to understand the surgical anatomy of the breast. So, if I quickly put it into the surgical anatomy of breast. In the surgical anatomy of the breast, in order to understand, we'll depict the same, right? So this takes the representation of neck. This is the shoulder line. Let's say this is the upper limb that is present. This is the arm and this continues across, right? Now this happens to be the suprasternal notch. It continues into sternum, turns into xiphisternum, right? Now, when you look at the upper limb, the axilla, I'll just highlight it. This is how the axilla is going to look, right? Now, I'll say this is the anterior axillary line. This is the posterior axillary line. And just for the sake of understanding, I will say this is your mid-axillary line. So, we have divided the axilla into three distinct contents: the anterior axillary line, the mid-axillary line, and the posterior axillary line. Then you see that there is this axillary groove is present. So, this is how the axillary groove is represented. And for the sake of understanding, and this is how I'm going to represent the clavicle, right? So, this is how the clavicle is being represented across here. Now, I need to know what is the true extent of the breast. When you look at the true extent of the breast, I need to know the superior extent of the breast, I need to know the medial extent, I need to know the lateral extent, I need to know the inferior extent as well. Now, the superior extent of the breast, the superior, Devam will try to give you the precise answers and locations. This is going to be your surgeon's perspective towards your anatomy. The anatomy that you read in your first year is a crude anatomy. I know you would have read a bit of implications, but then when you look at it from a surgeon's point of view, it changes dramatically. It is the same thing, no? When you look at a picture, right, or a painting or something. If you don't understand what to look at it, it's just a painting. But when you start looking at it carefully, you will see the color, you will see the palette, you will see the strokes, you will see how complex the layers of the colors are. That is how you appreciate when you start knowing things, and that is the beauty of surgery. You understand anatomy, okay, but then you start implying it and you start treating the patient using that anatomy, and then you operate, dissect and remove it. That gives you a lot of, it's a work of responsibility. So when you dig deep into the subject and you try to understand what exactly it is, and that is where the original beauty lies. Okay? Now, when I say the true extent of the breast, the superior extent of the breast starts from the inferior border of the clavicle. The medial extent is going to be the lateral border of the sternum. Then you have the inframammary fold as the inferior extent, and the lateral extent is going to be your anterior axillary line, and this happens to be your nipple areolar complex. Okay? So when you look at the breast, this is the true extent or the clinical extent of the breast. Now, if I highlight it, what is the clinical extent of the breast? You see, this is the superior extent, right? When I say the superior extent of the breast, it is by the inferior. It is by the inferior border of clavicle. It is the inferior border of the clavicle. Then you look, this is the lateral extent. The lateral extent is formed by the anterior axillary line. It is formed by the anterior axillary line. Then you have the inferior extent. The inferior extent is formed by the inframammary fold. It is formed by the inframammary fold. And the last one that you have is the medial extent of the breast. So when you look at the medial extent of the breast, it is formed by the lateral border of the sternum. It is formed by the lateral border of sternum. It is formed by the lateral border of the sternum. So this is the true extent of the breast. So clinically, when you look at the breast, the craniocaudal extension is going to be from the inferior border of the clavicle to the inframammary fold. The mediolateral extension is going to be from the lateral border of the sternum to that of the anterior axillary line. Now, why this is important is whenever you're doing a breast surgery, let's say you're doing an MRM, that is a modified radical mastectomy, or you're doing a simple mastectomy, I have to remove the entire breast tissue. So when I say the entire breast tissue, this entire breast tissue comprises of this area. So this is the area that I have to go and remove it. So when I'm dissecting the breast, when I'm dissecting the breast, I know the superior extent. So normally, okay, so as we go across, let's say you want to do a breast surgery, right? See, incision you have to put, right? So the incisions in the breast surgery is going to be usually an elliptical incision. So one, I will not extend the incision beyond the extent of the breast. So my incision will always be from the lateral border of the sternum to the anterior axillary line. I cannot cross the incision because breast वहां पे खत्म ही हो जाता है. जहां breast है ही नहीं वहां incision क्या करोगे? तो incision वहीं पे लगाओगे जहां पे आपका breast शुरू होता है, जहां पे खत्म होता है. तो हमारा शुरू breast यहाँ पे lateral border of sternum से हो रहा है, anterior axillary line पे खत्म हो रहा है. तो incision इन दोनों के बीच में होगा, खत्म बात. ठीक है. अगर if I take this entire area, अगर मैं incision ऐसे लगाता हूं जैसे मेरी dotted line है, उस इंसिशन में इतना बड़ा आप ब्रेस्ट का स्किन भी निकाल दोगे, इसको क्लोज कैसे करोगे? इतना बड़ा डिफेक्ट हो जाएगा, राइट? सो टू अवॉइड दैट यूजुअली वी कीप एन एलिप्टिकल इंसिशन. सो फर्स्ट, जब आपको ट्रू एक्सटेंट ऑफ द ब्रेस्ट पता है, यू नो वेयर टू स्टार्ट द इंसिशन, वेयर टू एंड. पहली बात क्लियर है. फिर बारी आती है कि व्हेन यू स्टार्ट डिगिंग इट, नो, यू आर ट्राइंग टू डिसेक्ट इट. तो ये आपका स्किन फ्लैप है, ठीक है. सो दिस इज योर सुपीरियर फ्लैप, शेडेड एरिया आपका स्किन का फ्लैप है ऊपर वाला, और दिस इज योर इंफीरियर फ्लैप, ठीक है. आपने इंसिशन दिया, इंसिशन देने के बाद यू स्टार्ट डिगिंग इन, राइट. नाउ वंस यू लिफ्ट द स्किन एंड यू स्टार्ट टू डिग 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 डिग, कब तक, कहां तक डिग करोगे? यू ऐसे डिग करते रहोगे, ऐसे डिग करते रहोगे, करते 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 पता चला क्लैविकल के ऊपर चले गए, ऊपर नेक के ऊपर, यहां कहां तक जाओगे? देयर हैज टू बी अ लिमिट. नो, फॉर दैट यू नीड टू नो कि ब्रेस्ट कहां खत्म होता है. ब्रेस्ट कहां खत्म होता है? इंफीरियर बॉर्डर ऑफ द क्लैविकल. तो डिग करते 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 जैसे आपको इंफीरियर बॉर्डर ऑफ द क्लैविकल फील करेगा, आप बंद कर दोगे. ठीक है, मैं पहुंच गया अपने एक्सटेंट पे. सेम इंफीरियर इंफ्रामैमरी फोल्ड तक. When you go laterally, you go all the way to the anterior axillary fold, and then you go to the medial side, the lateral border of sternum. So, if you have a sound knowledge of the clinical anatomy of the breast, in surgery, it helps a great deal to plan your incision, to plan your dissection, to plan what is the extent to which you're going to dig through, right? So, all these are going to be put into perspectives. Okay? So, this is with respect to the clinical anatomy of the breast. Okay. Now, so you now know the basic orientation that we have already depicted, and this is the surgical anatomy which you need to get oriented to it as well. Now, when you dig deeper into the anatomy, you will realize that the entire breast anatomy, for our understanding, the entire component of the breast anatomy, I can divide them into two contexts or the two divisional parts. One we'll call it as the glandular component of the breast. Another one is the stromal component of the breast. So when you go deeper into the anatomy of the breast, when you dig deep, I can broadly divide the breast anatomy into two components. One is going to be the glandular component of the breast. Another one is what we call it as the stromal component of the breast, right? The name itself suggests, when I say the glandular component of the breast, it is responsible with secretions. So it is going to be responsible for secretion. Stroma word basically stands for support system. The word stroma basically stands for that of the support system. It stands for the support system, right? So let's understand and analyze that what are the points or the components of the glandular and the stromal component of the breast, right? When it comes down to the glandular component of the breast, now imagine that this is the representation of the breast, right? And we said that this is going to be the pectoralis fascia. So this is how the pectoralis fascia is, and this is where you have the nipple component. So when you see the glandular component of the breast, just to depict it, you will see there is a small duct which is present. It opens into a bigger duct or a dilated duct. Then you'll have a more broader or a wider duct. It is going to be added by the smaller branches, and you see these are blunted ends which are present. So this entire component is what we call it as the glandular part of the breast, or the glandular component of the breast. For the sake of understanding, I'm just going to number them. That is structure number 1, this is structure number 2, this is structure number 3, this is structure number 4, and this is structure number 5. So you have 5 different components which are present in the glandular component of the breast. Each and individual component is important because based upon that, once you know what is the precise location, you will be able to identify the pathologies that are going to arise from there. You can predict the symptoms that are going to be there. So if you know the parts and what do they do and what are their functions, I'll be able to predict that if a symptom is arise, probably the pathology is in that part of the breast, right? So let's quickly look at that. What are these parts? So the first one that you can see here, the first one that you see across here, okay, we'll use this column. The first part which you can see here, this is the last part of the entire glandular component. So this is what we call it as the terminal duct. Now this can be called as a terminal lactociferous duct, whatever it is, because it is ending into nipple. It is entire glandular part is terminating into the nipple. So this last part is the terminal portion, hence called as the terminal duct. Now then you see there is a wider component, right? Now wider component which is present here is an extension of this big duct. There's a big duct and it is becoming broader. एक duct जो चली आ रही है suddenly वो बड़ी मोटी होगी, ठीक है? That is a dilated component of it. So what is this? Now usually you will get confused between whether you will call it as an ampulla or shall I call it as a sinus. So I need to know what is the basic difference between an ampulla and what is a sinus. So when you say an ampulla or sinus, you see there is a duct, there is a dilatation, and then it continues with the duct. And you can see an ampulla will have a bidirectional communication. Sinus, on the other hand, is a blind ending tract. Sinus will only have entry, or there will be entry and exit is from the same point. So basically blind ending tract is what we call it as sinus. If you have both sided communication or bidirectional communication, it is called as an ampulla. So when you come to this diagram, you can see terminal duct is one communication, and then you have the structure number 3 is the other communication. So two-ended communication. Now with a two-ended communication, this would be called as the ampulla. This is what we call it as the ampulla of the glandular component, right? Now, the structure number 3, which is the biggest structure among all, or the biggest duct among all, this is what we call it as the major lactiferous duct. This is what we call it as the major lactiferous duct, right? So you have the terminal duct, you have the ampulla, then you have the major lactiferous duct. Now, after the major lactiferous duct, you have the smaller branching ducts which are present. The smaller branching ducts are what we call it as the minor, or also called as the branched lactiferous duct. The minor or the branched lactiferous duct. Now, usually the confusion is, what is structure number 5? What do you call this as the structure number 5? Now, in order to understand structure number 5, what do you think it is? Do you think it is an alveoli? Do you think it is a lobule? Or do you think it is a lobe? So you have 3 different options. Do you think it is an alveoli? Do you think it is a lobule? Or do you think it is a lobe? Now, if you go deeper into this, you will see there are true secretory organelles which are present. The true secretory organelles which are present inside this is what we call it as alveoli. The collection of alveoli is what we call it as the lobule. So the structure number 5 is actually a lobule. The structure number 5 is a lobule. So what is a lobe? A lobe is a combination of all. You'll see a lobe would be considered as a combination of all. You see, all these put together is what we call it as lobe, right? So you now know that the collection of alveoli is what we call it as lobule. A collection of lobule is what we call it as lobe. So this is the entire glandular unit of the breast. Now, the entire glandular unit of the breast is given a fancy name. Now, the fancy name for this is what we call it as, this is now we call it as TDLU, just to confuse you. What is this TDLU? TDLU stands for terminal ductal lobular unit. TDLU stands for terminal ductal. It is the terminal ductal lobular unit. TDLU stands for the terminal ductal lobular units, right? So it is a terminal ductal lobular unit together is what we call it as TDLUs. अगर आपसे पूछ ला कितने TDLUs, how many TDLUs are there per breast? Some textbooks say that 10 to 15 TDLUs that are going to be present per breast. And few of them say 12 to 15, it varies. So 10 to 15 is the broader margin that you can say. So in a single breast, you will have 10 to 15 TDLUs which are going to be present per breast. Okay? So this is in terms of the glandular part of the breast. So whenever we talk about any disorders or any pathology that is going to exist in breast, we'll be addressing to these sites. We'll be saying whether it says, is it terminal ductal in origin, or is it going to be from the ampulla, or is it going to be from the major lactiferous duct, is it a lobular pathology? There are a lot of, if and but when we keep moving across it. But then if you understand the exact precise location, I'll be able to tell you that exact pathology from where it is going to originate. So that's the basic objective behind telling you about the basic anatomy of the glandular component. Now, what is interesting is it is the stromal anatomy. So when you look at the stromal anatomy, again, we'll take the representation of the breast. So this is the breast that we have depicted. This is the nipple that you have. And let's say this is the pectoralis fascia, right? Just for the sake of understanding, I'll be drawing couple of TDLUs. I'll be depicting couple of TDLUs so that you understand the basic anatomical orientation. So these are the TDLUs that you have. We have 10 to 15. I'm going to depict couple of them, that is 2 to 3, so that you understand it better. So these are the various TDLUs that we have. Now, as the stroma says that it is the support system, right? So let's understand and analyze what all qualifies to be the support system. The most important support system is the packing material of the breast, which is here. So you see there is this structure which I'm drawing in front of you, which is going to be present between the glandular components. In fact, it provides a nice cushion to the glandular component. It will not allow one glandular component to interfere with the another. So it is like a packing material. So it's like a bubble wrap also. It wraps the glandular component. It won't allow one glandular component to interfere with another, and it keeps it isolated. At the same time, it also acts as a cushion to the breast, so that if there is any injury or trauma that occurs to the breast, no, it won't allow the trauma or the traumatic injury to cause damage to the glandular component. So this is the most important stromal component which is guarding the breast, right? Now, I hope everybody has gotten the idea. So this stromal component that I have tried to depict in front of you, this stromal component is going to be your adipose tissue, or also called as the fatty tissue, right? The adipose or the fatty tissue is the major stromal component of the breast. It provides you with the support system. It provides you with the shape and contour of the breast. It provides you with protection to the glandular component. It provides you as the packing or the cushion material, so that it does not cause any interference between two glandular structures, prevents from traumatic injuries, prevents any further interaction between the two glandular components. मैं कहने का मतलब ये है कि अगर स्ट्रोमा होता नहीं तो जितने भी आपके टीडियल्यूस ऊपर है ना, नीचे वाले टीडियल्यू को दबा देते, अगर वो दब जाते तो obviously you would have all the dependent टीडियल्यूस would have become atrophic. Body says I will not let this happen, so they've intervened with this fatty material which is going to make sure that a TDLU does not interfere with one and another, and that's the basic objective. Now, as you can see, that this is the pectoralis fascia which is present behind, right? Now, from the pectoralis fascia itself, you see there is a fascia that is going to originate, and it is going to engulf the basic breast component, right? It actually encases the glandular component completely. Now, this which is going to encase it, you can see here this green structure that we have drawn. This is what we call it as the pre-mammary fascia. This is what we call it as the pre-mammary fascia. This is what we call it as the pre-mammary fascia. Now, this pre-mammary fascia is going to be adherent tightly. It encases your entire glandular component which is there. Now, what happens is, from the pre-mammary fascia, you will notice, so this is the outer extent of the breast. I can say this is the breast skin that we're talking about. This is the breast skin that is present across here, right? So you will notice that this pre-mammary fascia will give rise to these strands, and these strands are going to be attached to the overlying skin, and they are going to be continuous. They are going to be continuous with the pre-mammary fascia. They are going to be continuous with the pre-mammary fascia. They are going to be continuous with the pre-mammary fascia. So these structures or these strands which you can see, which are arising, or I can say which is attached. When you look at this, the attachment is between the pre-mammary fascia and the skin, and these attachments is what we call it as the suspensory ligaments of Cooper. These are what we call it as the suspensory ligaments. It is the suspensory ligaments of Cooper, or also commonly referred to as the Ashley's-Cooper's ligament. Also referred to as the Ashley's-Cooper's ligament. So if you look at the suspensory ligaments of Cooper, they are nothing but, if you trace the suspensory ligaments of Cooper, this is the suspensory ligament of Cooper. It is attaching to the skin. It goes into the pre-mammary fascia, and this pre-mammary fascia attaches to that of the pectoralis fascia, right? I repeat again, when you look at the suspensory ligament of Cooper, anteriorly it is attaching to the skin. So this is the overlying skin that I can tell you. So this is the skin that you have, and posteriorly you have the pectoralis fascia. Posteriorly you have the pectoralis fascia. This is the pectoralis fascia. This happens to be the pectoralis fascia, right? So if you look at the suspensory ligaments of Cooper, the suspensory ligaments of Cooper starts from the skin and goes on to the pectoralis fascia via the premammary fascia. So premammary fascia is actually an amalgamation. So if you look at very carefully, now there's a beautiful depiction. You see all these suspensory ligaments of Cooper, they all merge together. Now as they merge together, this merging of the suspensory ligaments of Cooper, this merging of the suspensory ligaments of Cooper is what we call it as the premammary fascia. It has premammary fascia, right? So premammary fascia is a fancy word to tell you it is an suspensory ligaments of Cooper that is extending from the skin to that of the pectoralis fascia, and that too in a radial manner. So it is like from the skin all the way to the central component. Okay? So this is how you have the arrangement of the suspensory ligaments of Cooper. I hope I'm able to give you a concept and the basic depiction behind it, because it's a very, very basic thing that you should know. Otherwise, as we talk about symptomatology, it will become difficult, right? As we go down, I'll tell you about dimpling, where the skin is being indrawn. If a tumor arises from here and a tumor encases the Cooper's ligament, it pulls. Now, as the Cooper ligament is pulled, the skin is going to be pulled towards the lump, and that indrawing of the skin towards the lump indicates there's an infiltration of Cooper's ligament. There's an infiltration of Cooper's ligament, right? So this is the basic anatomical orientation that you need to know with the glandular and the stromal component. So in the stroma, what did we have? So in the stroma, we had two important things. One is the adipose tissue. One happens to be the adipose tissue. Another one is going to be your Cooper's ligament. Another one is going to be your Cooper's ligament. Okay? So this concludes your glandular and the stromal component of the breast. Clear? Okay. So we started with the basic orientation, how it looks. We dig deep and we now found the microanatomy of the breast, that is the glandular and the stromal component of the breast. Now what is even more important, it is the breast lymphatics, right? So we'll talk about breast lymphatics. So when we talk about the breast lymphatics, the principal drainage of the breast is carried out by two major groups, right? So two set of lymphatics which are going to drain the breast lymph nodes. Now what are the two basic sets? One is going to be the axillary group of lymph nodes. One, we have the axillary group of lymphatics. Another one is going to be the internal mammary group of lymphatics. Internal mammary group of lymphatics. So one, we have the axillary group, another one is the internal mammary group of the lymphatics, right? So when you look at the entire lymphatic drainage, around 75% of the breast lymphatics are carried out by axillary group. Around 15 to 20% it is carried by the internal mammary, and then you have miscellaneous smaller groups which are going to carry out for 5 to 10 other components, or 5 to 10% of the rest of the breast lymphatics. When you look at the axillary group of lymphatics, the axillary group of lymphatics are further divided into three subsets. Usually it is along the blood vessel, but we have an easier depiction to give also. We have the anterior group. We have the posterior group, and then you have the lateral group. You have the anterior group, the posterior group, and the lateral group of breast lymphatics, which are the axillary group of lymph nodes, and together they are going to drain the breast per se. So you look at this now. So let's understand the clinical orientation towards it. So we'll have two different components. One is the anatomical orientation, and the other one will be your surgical division, right? So we'll try to understand the difference between those two. Anatomical will be your basic one, surgical will be from a surgeon's standpoint. As I told you, the art is best appreciated when you look through an artist's vision, and that is the basic component about your surgical division of the breast lymphatics. Okay? So we'll try to understand, analyze both of them. So we'll give you what is the difference between the surgical and the anatomical division of the breast lymphatics. So we'll look at the anatomical division. We'll have the same depiction. This is the representation of the neck. This is the shoulder line. This is the upper limb, and this continues across here. So this happens to be suprasternal notch, this happens to be sternum, this is your xiphisternum, right? So this is the division of the axilla that you have. This is the anterior axillary line, this is the posterior axillary line, and then as an imaginary right in the center, we'll say this is a mid axillary line. Now this happens to be the clavicle, so I'm just going to make a bit towards from here. Right. So let's say this happens to be the clavicle for the sake of understanding, and this is the axillary groove, right? So this we all knew from our previous depiction only. That's the basic concept that you have, right? For the sake of understanding, this is the normal extent of the breast that we have spoken across, right? So this is the nipple areolar complex. So when you talk about the lymph nodes, the axillary group of lymph nodes, I told you there are three sets of axillary group of lymph nodes. What are the three sets? We have the anterior axillary group of lymph nodes, we have the posterior axillary group of lymph nodes, and then you have the lateral axillary group of lymph nodes, right? So when you look at the lymph nodes, the axilla is three sets: anterior axillary, the posterior axillary, and the lateral axillary group of lymph nodes. Lateral is present on the medial aspect of the upper arm, right? Do not goof up with that. So you have three sets of lymph nodes that you have. This is the anterior axillary. So we say ALN, that is axillary group of lymph nodes. This is the posterior axillary group of lymph nodes, and this happens to be the lateral axillary group of lymph nodes. The three sets of lymph nodes are present in the axilla: the anterior group, the posterior group, and the lateral axillary group of lymph nodes, right? Then when you look into deep into the axillary groove, deep inside the axillary groove, you see another lymph node that is going to be present. The lymph node which is present deep in the axillary groove. Lymph nodes present deep in the axillary groove. This is what we call it as the central group of lymph nodes. This is what we call it as the central group of lymph node. This is what we call it as the central group of lymph node. The one that is present under the clavicle on the medial aspect, this is what we call it as the apical group. This is what we call it as the apical group of lymph nodes. The lymph nodes which are present along the lateral border of the sternum, these are what we call it as the internal mammary group of lymph nodes. These are what we call it as the internal mammary group of lymph nodes. This is your internal mammary group of lymph nodes. There's an internal mammary group of lymph nodes. You see, so axillary group and the internal mammary group are the basic set. You see the axillary is into anterior, posterior, lateral. Then you have internal mammary. Then you have central and the apical group. There's a small set of lymph nodes which are going to be present here, which is slightly on the lateral side. And this set of lymph nodes which are present here, these are what we call it as the interpectoral, or also called as the Rotter's group. They're called as the interpectoral. They're called as the interpectoral group, or also referred to as the Rotter's group of lymphatics. They're also called as the Rotter's group of breast lymphatics, right? So these are the various lymphatics which are going to be present. So this is the axillary group, this is the internal mammary, the Rotter's group, the central and the apical group of lymph nodes. So when you look at the pattern of lymphatic drainage, you will notice, look at the pattern of the lymphatic drainage, you will notice that all these lymphatics, the axillary group, they drain into central. From the central, it drains into apical. All the internal mammary nodes also drain into apical. The Rotter also drains into apical, right? There's a basic drainage of the lymphatics that you will see, that all these breast lymphatics drain down into your apical group of lymph nodes. it drains down into the apical group of lymph nodes. And this is your lymphatics or the breast lymphatics which are present. There's another, just for the sake of understanding, there's something called as the Sapes plexus. The Sapes plexus are the lymphatics that drain the nipple and the areolar complex. So nipple and areolar lymphatic drainage. The nipple and the areolar lymphatic drainage is what we call it as the Sapes plexus. This is what we call it as the Sapes plexus. Okay? But again, as I told you, the anatomical divisions are not good enough for you to plan your surgeries. So hence you have the surgical division. Now the surgical division is again quite similar to what of anatomical, but there's a tinge of difference that you have. This is the neck. This happens to be shoulder line. This happens to be the upper limb, and this continues across. This happens to be the suprasternal notch. This is the sternum. This is ephisternum. This happens to be the clavicle. This is the axillary groove that you have, and this is the axillary line that you have, right? Now, the surgical division of the breast lymphatics are done on the basis of a muscle, and that muscle is going to be a pectoralis minor that originates from the coracoid process, inserts onto the third, fourth, and the fifth rib. So this is the orientation of the muscle, that is your pectoralis minor muscle. So based upon this muscle, I am going to divide the breast lymphatics into three different levels. So it is the pectoralis minor that is going to decide that what is the level of lymphatics that you're going to talk about. Now how do you do so? The simplest way is draw one line that crosses the superior border of the pectoralis minor muscle. Draw another line that is going to cross the inferior border of the pectoralis minor muscle, and now you have three distinctive zones which are present, right? So if you look at this, you have this is as one zone. So whatever lymphatics which are going to be present in this area, this is what we call it as the level 1 of the breast lymphatics. This is what we call it as the level 1 of the breast lymphatics. Whatever will be present in this is what we call it as the level 2 of the breast lymphatics. This will be called as the level 2 of the breast lymphatics. And whichever is going to be present above this will be called as the level 3 of the breast lymphatics. This is what we call it as the level 3 of the breast lymphatics, right? So you can see the pectoralis minor muscle. So simply by drawing a small muscle, and this is our pectoralis minor muscle. The pectoralis minor muscle, when you look at the origin, it originates from the coracoid process, inserts onto the third, fourth, and fifth rib. It divides the entire chest into three distinctive zones, and this is what we call it as the level 1. This is what we call it as the level 2. And this is what we call it as the level 3 group of breast lymphatics, right? So pectoralis minor muscle has divided the entire context or entire division into three distinctive levels, right? So what are these levels when you look at this, right? So look at this, we have the level 1 group of lymphatics. When I say level 1, any lymph nodes which are going to be present lateral, they're going to be lateral and below pectoralis minor muscle. All those lymph nodes which are going to be present lateral and below pectoralis minor will be level 1. So you have both the anatomical and the surgical division in comparison to that. You're talking about lateral and below. You're talking about lateral and below. What are lateral and below? All the axillary group of lymph nodes, right? So you have the anterior axillary group of lymph nodes, the anterior axillary group of lymph nodes. We have the posterior axillary group of lymph nodes and the lateral axillary group of lymph nodes. All these will be called as the level 1. Then you have level 2. What does level 2 qualify as? Level 2 is what? Which are going to be present at the level of the pectoralis minor. These are present at the level of pectoralis minor muscle. Now, at the level of pectoralis minor muscle, you only have one set of lymphatics, and that is going to be your central, and the other one is rotus. Okay? So, you have two lymphatics. You have the central group. And then you have the rotors group. You have the central group as well as the rotors group. Last one that you have is going to be the level 3 group of lymph nodes. As you can see, level 3 group of lymph nodes, the lymph nodes are present medial and above to pectoralis minor. They are present medial and above. They are present medial and above pectoralis minor muscle. They are present medial and above the pectoralis minor muscle. So what are the lymph nodes which are going to be present here? It is going to be the apical group. It is going to be the apical group, which will be classified as level 3 group of lymph nodes. So whenever we're doing a breast surgery, in the breast surgery, we'll always talk about removing of level 1, removal of level 2 or level 3. We'll not talk about the named lymph nodes. We'll talk about the levels of lymph nodes which are going to be shown across here. Now my question to you is, when you see both these divisions, you see the surgical division, you see that of the anatomical division. There is one lymph node which I have written in the anatomical one, but I don't have in the surgical one. What is that? Time for you to spot. Right. So the lymph node which are present in the anatomical but not there in the surgical is your internal mammary group of lymph nodes. Why is that so? You need to understand the whole idea of creating the surgical division of the breast lymphatics is to remove during surgery. Now the question is, why do you want to remove the lymph nodes during surgery? Obvious answer is, if it is a breast cancer, if there's a malignant lesion involving the lymph nodes, I would like to do a lymph node clearance. Okay. Now lymph node clearances or the lymph node can be rendered either by surgical removal or by doing a radiotherapy. Okay. Wherever radiotherapy is possible, I will resort to radiotherapy because it is less invasive. But wherever it is not possible, I'll go with surgery. The best example is axilla. Now, whenever you do a radiotherapy or when you give radiation, it not only ablates that particular tissue, but it also causes a peritissue ablation. That means there's a lot of inflammation and there's a lot of injury that is going to occur around the tissue also. It is not specific to that particular area. Now, if you give radiotherapy into the axilla, it will no doubt, it will kill the lymph nodes. It will absolutely burn out. But at the same time, when you are going to give radiotherapy to the axilla, not only the lymph nodes, other axillary structures are going to be hampered. Example like axillary artery, axillary vein, brachial plexus, the whole arm will become renderous. Now, just to go and do a non-invasive method to kill a lymph node, you are making the patient's hand renderous, right? Now, this risk to benefit ratio is useless. No, you're looking for cosmesis and you are leaving away the arm. So hence, you cannot give radiotherapy into the axilla. Hence, I will go ahead with surgical removal only. When it comes to the internal mammary group of lymph nodes, one, the involvement is not that common, and even if it is involved, you don't need to go and dissect it and surgically remove it, because post-operative radiotherapy can be given here. There are no vital structures here. The nodes can be ablated without causing much surgical dissection. So internal mammary nodes can be taken care with radiotherapy. They do not require a surgical excision. When you do not require a surgical excision, it does not make any sense to classify them surgically. Hence, the internal mammary group of lymph nodes are not classified in the surgical levels, but they will be depicted in your anatomical context. Yes, we'll consider them when we go with TNM staging, but then for the surgical division, this is what you have to remember, and for the anatomical orientation, this is what you have to remember, right? So this was our opening class for the breast. So it is the basic anatomical orientation that I wanted you to have it. Now that you know the true extent of the breast, you know the breast lymphatics, you know the micro anatomical component of the breast, it makes my job much more easier to take you into an on drive for a beautiful lecture of the rest of the pathologies in the breast, right? So thank you so much for joining today. We'll continue tomorrow, same time, that is 9 o'clock. We'll continue with where we left out. Tomorrow we'll talk about the benign disorders of the breast as well as the congenital disorders, and then we'll take it on from there, right? You know where to reach out if you have any questions, any queries. You can always reach down to the Instagram and the Telegram group. It is the Surgery Guy. You'll find the group on both Telegram as well as Instagram. It is by my name. You will find the name as well. This is your Dr. Sandeep Reddy. Right. So thank you so much for joining today. We'll see you tomorrow at 9 o'clock. Thank you. Good night.